Councillor Zaman, we're live, so if you want to kick off the meeting, please.
Okay, thank you, Richard. Good afternoon and welcome to the Health and Adult Social Care Scrutiny Panel meeting. We are live on webcast this afternoon, and if people attending the meeting can turn off their cameras when they're not speaking and put their mics on mute, so we can avoid any background noise. This afternoon we have apologies from Councillor Fazila Lunat and Councillor Vivian Lees Hamilton. Can we move on to minutes of the previous meeting of the panel held on the 25th of February? Any matters arising from the minutes? Okay, can we record them as a true record? Okay, thank you for that. Thank you. Okay, item number 2 is interest. So if any councillors have any interest that they would like to disclose, which would prevent them from participating in any of the discussions, if they can complete the form and submit that to Richard after the meeting. We are
sorry, Councillor Zaman, if we could just go around just to clarify if there are any interests that need to be declared, please.
Okay. Any interest to declare?
Yes, Linked Co-op Tea. I just wish to declare that I'm a volunteer with Health Watch, Calderdale and Kirklees. Thank you.
Leslie Warner. I'm involved as a governor with the Calderdale and Huddersfield NHS Trust, or rather I am.
Thank you. Anybody else? Okay, thank you for that. We have no deputations or petitions for this meeting, and we have no questions from the public. So if we can move on to item 6, which is the impact of COVID-19 on Kirklees Acute Hospital Trusts. For this item, we have the Calderdale and Huddersfield NHS Foundation Trust and the Mid Yorkshire Hospitals NHS Trust in attendance, and they will be giving us an overview of some of the issues that they've come under as part of their responsibility in delivering services. I will ask the Calderdale and Huddersfield NHS Trust, first of all, to give us a brief 5-minute overview of some of the key challenges that you may have faced in this period, and then we can move on to the Mid Yorkshire NHS Trust.
Okay, so thank you very much. Hello, my name's Anna Basford. I'm Director of Transformation and Partnerships at Calderdale and Huddersfield Foundation Trust. We submitted with the papers a set of slides which hopefully address the key areas where you'd asked us to provide update and information to you. Be happy to answer questions relevant to any of the points raised within those papers. I think in terms of the points that I would highlight in relation to that, in terms of the number of people that we've tested as a hospital during this period of the pandemic, as of this week, a slight update, that's 12,000 people that we've tested, and we've had just over 500 people reporting as positive results in relation to that. The number of people that unfortunately have died, having tested positive and then died in the hospital, is 155. We have in recent weeks, seen a reduction in the numbers of people coming to hospital that are testing as positive, and we have a low number of people currently as inpatients in the hospital. We've included in our data pack information in relation to the way that we've segregated areas of the hospital, and also in terms of some of the demographics. I'm aware that my colleague David Birkenhead has just joined the meeting. He's medical director, and I just wonder, David, if you perhaps wanted to just cover those points.
Yeah, happy to, Anna. Thank you. So Yeah, sorry for being late, everyone. I was in another meeting. So I think I was given the context. You know, COVID's been quite a challenge within CHFT over the last 4 or 5 months, as it has been for everybody. 10,000 patients tested, 498 positive, 153 COVID deaths, but a lot of patients also discharged well, and quite a few of our staff absent as well from work due to a variety of reasons, often because they were in a vulnerable group and having to shield, but also others who had contact with potential COVID and had to self-isolate. And so we've been having around about 200 staff absent over that period of time. That figure's been fairly consistent. So, you know, if we look at the demographics on who we've been seeing over that period and what's been happening to them, so we've certainly, at least within the hospital environment anyway, seen fewer non-COVID deaths. We haven't really analysed why that might be yet when compared to previous years, but it may be that those people in Colindale and Kirklees may have died, but not in hospital, because they were less likely to present to the trust. You know, like I think it's been described nationally, more males than females. Males seem to be at a higher risk of severe complications from COVID. So we've had twice as many males, unfortunately, passed away than females. And again, we've seen quite a significant increase in the mortality rate with increasing age, with our peak age range between 80 and 90. Unlike the national picture, perhaps, the ethnicity of our patients hasn't really you know, and the increase in mortality amongst people from a non-white background really hasn't been seen within CHFT, and that mortality rates have been very similar from the BAME community and from the white population. So it doesn't seem to have played out what we've seen nationally within CHFT. Well, the majority of patients who died, and again, it's probably not surprising given their age, have had multiple comorbidities, so other medical conditions, and in particular diabetes or ischemic heart disease and other respiratory illness. As you can see, a number of conditions in those patients. Chronic kidney disease, hypertension, and dementia, and again, I think that's reflected nationally in that many people who were succumbing to COVID had other medical conditions. So that the key risk factors for us seem to be age first, and then comorbidity, and then probably being male. So I think that's the demographics. In terms of, I think, Anna, do you want to carry on with the slides? So I think the next one looks at finance. So clearly the financial situation's been relaxed a little bit in order for the trust to manage COVID, and the additional resources it's needed have been provided. So we've incurred an additional 6.8 million in additional costs, and those have been funded nationally. Financial forecast assumes trust will continue to receive our CCG clinical income at the current activity levels, and that COVID costs and activity will remain broadly at a level similar to those seen in May, and we'll continue to have access to top-up funding because we still have, much work to do in terms of keeping patients safe, and we can't get back to our previous levels of activity at this point in time, given the restrictions on COVID and the need to maintain good infection control practice. So that maintains a real challenge for us moving forwards. If I look at pathways to care, so this describes, I think, some of the things, although by no means all of the things that we've had to do and implement to manage COVID over the last 5 months or so. So we've had to segregate both of our emergency departments into an area which will receive patients who may have COVID, and for those who are presenting for other reasons. So you can imagine that that's quite difficult to do operationally, and that's been done at both CRH and HRI, but clearly absolutely essential to do that. We've had to make sure that we were able to care for those patients safely and not in contact with others whilst they've been in our A&E department, that we have sufficient oxygen supply within the A&E if those patients need it. Through all that period of time, we've had to continue to provide, our normal emergency care services for non-COVID conditions. So those have not gone away. I think it's true to say that a lot of the more minor conditions that might have presented to our A&E before COVID probably haven't. So that's helped the department manage, I think, and those conditions have been managed elsewhere or self-managed. But clearly, those who did need hospital emergency care have still been presenting. We've had to consolidate some of our services on a single site on a temporary basis, including ambulatory care and chemotherapy. Again, that's been to make sure that we can provide a safe environment for those patients where they can be protected from coming into contact with other patients who may have or be suspected to have COVID. But I think we've managed to reverse those changes now. And importantly, we've had to make sure that all patients who are COVID positive or suspected to be COVID positive are cared for in side rooms, and we have a very limited supply of side rooms in the organisation, so that's been quite a challenge for us as well. But nonetheless, we've managed to achieve that. The signs and symptoms of COVID are not unique; they are common to other respiratory illnesses. So, it's far more patients who we've needed to put into side rooms than have actually been diagnosed with COVID ultimately. And even those where we're pretty sure clinically that they've got COVID, even if they test negative, we still made sure that they remain in side rooms or in a cohorted ward area with other patients in a similar situation to make sure that we don't transmit COVID from patient to patient within the hospital. And we've also made sure that we test all of our admissions from residential care facilities, because we recognise that people coming from residential care were more likely to be positive. So those have gone into a side room as well, irrespective of the symptoms that they may have been having, because again, COVID can present in a atypical manner, so it doesn't always present with shortness of breath and respiratory symptoms. It can sometimes present with abdominal pain and other signs and symptoms. So we've made sure as far as we are able, to care for those patients as well in side room accommodation. According to national guidance, we've tested all patients on admission, and we test after 5 days if they're negative on their first test. We haven't found many positive after 5 days who haven't been tested positive on admission, I have to say, but occasionally that happens. And if that does happen and they've been in contact with other patients or staff, and it's unexpected, then we will need to do contact tracing to make sure that those people are aware. And we've been testing.
David, can we start wrapping up, because I did say 5 minutes.
Okay, sorry, I missed that bit. Okay, yeah, I'm very happy. I can take the rest as read. There's an awful lot that we've done, super green areas to make sure that patients are protected who are having surgery moving forwards. Again, those are people who are asked to go to self-isolation for 14 days, and we've been collaborating with the independent sector as well to make sure that we've got adequate capacity. So I'll finish there.
Okay, thank you for that. Do you want to take questions now, or shall we listen to the other trust and then come back? Members, you have a choice, or?
I don't know. I'm easy to take questions now. I'm sure Anna would be as well. There are one or two other slides that we've included for you about obviously making.
Yeah, if they're already on the presentation, members have had sight of that.
Yeah, so we're happy to take questions on those as well, but clearly it impacts on how we plan for the future in a different environment.
Can I just ask you a question in terms of, you mentioned that males are at a higher risk from the virus. Can I ask you why that is?
I don't think we know. I mean, they're not at higher risk of acquiring the virus, because that's equal between males and females. What they are at high risk for, it would appear, is getting more severe symptoms and potentially dying from the virus, and that's a national picture. You see that, well, not just in the UK. It may be related to their immune systems, which as you get older, your immune system becomes less effective, and it may be that the male immune system deteriorates faster or than females. The honest answer to that is we don't really know at this point in time. It's subject to ongoing research.
Okay. Any further questions, or shall we move on? Peter, are you wanting to ask a question? Alison?
Yes, please. I'm sorry, I'm just in the looking at the chat. I think Dave's also indicated that he wanted to speak earlier. I just wanted to ask a question in terms of the numbers. So for patients testing positive for COVID-19 who require hospitalization, how many can you actually handle? How many people can you physically take in? It's a numbers question, really.
Okay, so I think when we were planning for COVID, we planned on a worst case scenario of around about a maximum of 400 patients coming into the organisation, and potentially 70 being needing intensive care support. I have to say we didn't get anywhere near that number. I think the maximum we had on intensive care was about 23, and I think the maximum number of patients with COVID we had in the organisation at any one time was somewhere between 70 and 80.
Right. So you've got capacity. I'm thinking for the future in the winter, if there's a second wave as such, that you have got plenty of capacity there.
Yeah, I mean,
it's good to hear.
Yes, we've got the Nightingale as well, clearly, which we could potentially have accessed, but we didn't need to in terms of intensive care. The winter will present other challenges because it's not just COVID that we'll have to manage through winter, it's influenza and other respiratory illnesses, so that will potentially be more challenging for us.
If I may,
Right,
just to say that capacity is enabled by us stopping some routine work that we do, some planned services. So obviously one of the challenges to create that capacity is we have had to slow down or suspend some of our elective pathways to free up that capacity, and that is a challenge, and would also feature, should we see a second surge, an impact on for non-urgent care.
Yeah, it's a really difficult balancing act, isn't it? I'm sure it must be a nightmare to actually be trying to organise it all. Okay, thank you very much for that. Thank you.
Okay, can we move on to the Mid Yorkshire Trust? And
sorry, I do have some questions on this report. It's Dave.
All right. Okay. Okay, Dave, if you want to quickly ask us some of the questions, I'm just conscious that might be overlapping with the other trust as well. But yeah, go ahead.
I've got 4 questions. The first one's on something that David said about testing people before they come into hospital. I just wonder what the arrangements are for testing before patients are discharged back to care homes. That's the first question. And then the other 3 are on the report. First of all, there's a reference on the pathways to care of the use of face masks. I just wondered whether that's being working okay, whether visitors, patients and staff are all wearing face masks. The next question is about the availability of PPE. Is that still an issue, or has that been sorted out? And then the final one is in relation to preparing for winter. I just wondered if you have any information about when the flu vaccination programme is likely to begin, because I've read about the issues around both risks of flu and risks of the pandemic. So I just wondered how early that flu vaccination programme would start. Thank you.
Okay. I think so. I'll try and remember all of those questions, Councillor Rigby. If I forget one, then please remind me. So I think the first one was on.
I'm a co-op T, not a councillor.
Co-op T, okay. So I think the first one was on testing, and so patients who are discharged to residential care homes are all tested within 48 hours of discharge. So we plan that and we test them, and they're not discharged if they prove to be positive. In terms of testing, everybody's tested on admission, so they're not really patients we're testing in the community. They're patients who've presented to the organisation for admission. And as I said, I think I said we've got tested over 10,000 people, I think, and we've had, the numbers are updated a little bit since then. I think we've got a few more positives, over 500 positive patients now who tested. There's also a separate testing looking at antibodies to look at whether you've been exposed to COVID, and that will start to be done in community premises as well as the acute trust.
Thank you.
So I hope that answers the question on testing. In terms of face masks, so yeah, I think people are pretty compliant with the wearing of face masks in the organisation. We have people on our entries into the hospital just to remind people anyway, and to hand out a mask if they don't have one. And that pertains both to our staff and obviously any visitors that we have or patients. So compliance is good in terms of the wearing of face masks in the organisation. PPE has been a challenge, I think, but to be clear, we've never run out of PPE in the organisation, and we've never been in a position where we've not been able to supply PPE to our staff. I think it is easing now. It's easier than it was. We still have a very close eye on the availability of PPE and tend to meet 2 or 3 times a week just to assess that we have sufficient. But yeah, it's not a particular concern for us right now. And in terms of influenza and the winter, so the flu campaigns usually start around about October. I don't think we have a date yet, not one that I've seen anyway. But we started our planning for influenza now. It almost goes on throughout the year. And how we manage that, but we would normally start receiving the vaccine in September, October, and we'll commence vaccination at that point.
Okay, thank you for that. David, so some of these questions will overlap with the Mid Yorkshire Trust as well. So can we listen to them first and then see if there's any input from Health Watch as well before we move on to further questions, if that's okay with you?
Yeah, that's fine.
Okay, all right. Mid Yorkshire, who's doing the presentation on that? Is it Dave Martin?
Yeah, Dr. Andy Smith will be doing the presentation, or talking the presentation through, I should say. Yeah.
Okay, thank you very much, everybody. Yes, it's
5 minutes.
Hi, I shall try and stick to 5 minutes. Yes. Thank you for the invite. For people that don't know me, I'm the emergency medicine consultant at Mid Yorks, also associate medical director, particular responsibilities for major incident preparedness, and obviously COVID became within my remit, and now sit as a deputy chair for the Reset programme. So hopefully you've had a chance to look through the slide set that we submitted, which was a set of questions which we discussed through with Richard. And so equally, as pointed out earlier, so the patient profile was the same as discussed. If you're a male over the age of 60 with comorbidity, then you are at higher increase of risk. And out of people attending the hospital, which is around 15–20%, 5% required intensive care treatment. So the Trust, as I'm sure all trusts, implemented a COVID-19 incident plan. Initially at Mid Yorkshire, we had no testing capacity, but we were able to put that in place with time. And what is very clear with this major incident, this is not a sprint, it's a marathon. Hence, we are still managing and caring for patients suffering from COVID. Put in place was command and control very early on. Excellent communication team providing daily briefing and external communications throughout. And the executive team was very proactive in ensuring all were informed of the processes in place. We were able to track our decision making through several avenues. I'll just mention 2. So we had our strategic decision log, which was kept up to date, and any QIAs, so that's quality improvement actions or changes in practice, a log of those was kept throughout. One of my responsibilities was to submit what's known as an EPRR, Emergency Planning Resilience and Response report on the phase 1, and we covered all those aspects and provided that information in that report. So clearly, as my colleague from Calderdale Huddersfield has already mentioned, that we had red and green pathways in situ. Our emergency department was split and with the ability to flex up and flex down. And obviously at the moment we're in a position we can flex down from our COVID numbers. Hopefully it remains that well, but obviously we remain nervous for the winter. We had effective clinical groups, and some of the challenges we work differently, and that was important because if you take respiratory medicine, they sit in division of medicine. If you take critical care, surgery, but we very helpfully, effectively, and efficiently work collaboratively to ensure that we had a critical care cell that was reviewing all our patients requiring intensive care or HDU through the acute respiratory unit as one group, and I think that worked extremely well. We've talked about challenges with PPE. I think every trust was put under challenge around the PPE. The supply chain did not fulfil its requirements of the standards they set. And with the ICS group, we were able to offer mutual aid to each other and ensure that we were in a position where we could continue to care for our patients while keeping our staff safe. The welfare and well-being of our trust was key, and we extended our measures of the welfare and well-being on our intranet site with what we called wobble rooms for staff and psychological support throughout the processes, and the reports on that were extremely positive. You will see on one of the slides we produced the dates and events for us, and at our peak we had 170 patients in the trust on the 10th of April, and obviously that was an extremely busy time for us. We did provide you with the data around the Kirklees particularly, and you'll see the vast majority of our patients were white British. So I'm just looking at a table now. So number of this, we had community number of inpatients diagnosed with COVID-19 for the North Kirklees region was 230, 158 discharged. Sadly, there were 67 deaths. But the mean age of patients diagnosed with COVID-19 was 70.9. And the percentage of COVID deaths with associated comorbidity was 90.4%. So you can see that age and comorbidity were significant factors. The Trust obviously has increased its expenditure to manage the COVID crisis. Some of that is able to put down as a COVID expense, but the Trust obviously extended past that. Now, part of the review I've mentioned, the EPRR review, we looked at the lessons learnt, and I provided you quite a few aspects from there. The important thing was the command and control structure that we had in place, the clear communications. We allowed, where possible, for staff to work remotely, and having since increased our IT infrastructure to enable that. That allows staff to shield, but also reduce the footfall on the premises when we had the high number of COVID cases. We shifted to a 7-day management team, full team on site. And we worked, as I mentioned, collaboratively across clinical teams. We had significant changes in our estate, which were required to ensure the patient flows of green and red, and making sure that we now are able to continue with social distancing and try and reduce as much as possible any nosocomial spread. That is spread from staff to staff, staff to patients, patient to patients, patients to staff. And we continue to work through those processes at the moment. So you can clearly see from the slides that a lot of actions were put in place. A corporate nursing team were set up as a roving team to go around and support staff so they could understand donning and doffing and be supporting those processes. And we even converted one of our wards to an end-of-life ward, which really enabled for families and friends to come and say their goodbyes and for the appropriate care to be delivered. As my previous colleague said, we've had to change our flow, and we were lucky that we were able to maintain cancer care throughout, but clearly some of our elective pathways had to be suspended or reduced, and obviously we're in the process now of resetting those, bearing in mind the challenges that our estate has less capacity. We have to consider PPE requirements of donning and doffing. We have to consider airflow changes if we're what's called aerosol generating procedures. So our capacity is somewhat reduced compared to pre-COVID, but obviously we're looking to find innovative ways of working, and most of you know that our Pontefract site is now our cancer centre, so we can maintain that care as much as possible as before. I've mentioned the increased IT infrastructure, and the key thing, I'm cognizant of the time, is planning for the future surges of winter. Obviously, we're very nervous that winter's going to be challenging for the Trust. It has been for the last few years, but now we'll be managing COVID, flu, Norwalk, RSV, all the different viruses at the same time. And therefore, it's important that we're putting as much resilience into our planning to ensure that we'll be able to manage those surges in activity. Obviously, we're hoping the second surge is not worse than the first surge, as the government keeps telling us it may well be, but we're trying to ensure that we have sufficient PPE, that we have the pathways in place, and that we can accommodate these changes while trying to reset to as much as our previous activity prior to COVID as we can. And I hope you had the opportunity to look at the videos that we put into the last slide, which was showing some of our patients going home from intensive care. And there was a very good audio clip from a lady called Sally Ann about the care that was provided, which it was quite a moving clip to listen to. I'm happy to take questions.
Thank you. Can we bring Helen Hunter in from the Health Watch, please, and then Emily can come in after that. before we move on to further questions.
Hi, everybody. Just in case anybody doesn't know me, I'm Helen from Health Watch, but I think most scrutiny panel members have seen me far too often, I would say. I apologise, I had a bit of trouble online earlier, so if I break up at all, I do apologise. As you've asked for, I'm going to talk a little bit about the key bits of feedback that we've had, but if you do want any information about how Health Watch are gathering feedback at the moment, I'm more than happy to provide that as well. I'm going to try and keep it focused towards hospitals, but people's needs aren't as straightforward as this for the hospital, this for different places. So actually some of it overlaps with other feedback that we've heard as well. So first and foremost, what we heard in the first instance in terms of the hospital's response to COVID-19 was a huge amount of gratitude from members of the general public who were incredibly thankful for the commitment that people that work in the hospitals were making, the risk that they were exposing themselves to in order to try and keep them safe. And there was a really strong sense that people were incredibly appreciative. And that's been very, very clear throughout. We did see people talking to us about a couple of different reasons why they were perhaps avoiding accessing some health services. And so there were some people who were quite scared to go into go to the hospital if they needed to, and to go into other health settings because they were worried that they might contract COVID-19. There were also quite a lot of people who didn't want to be a bother to anybody during this period of time because they knew how busy everybody was, but actually perhaps that meant that they didn't prioritize their needs in the way that they should. And I would say that actually we are now hearing feedback that is more based around outpatients and around kind of elective care procedures rather than around kind of the care that is being delivered in the hospital at this moment. I think in the first instance, the people who talked to us were quite accepting of not being able to have a routine appointment because they understood the pressures on the system. But actually now that we are 4 months down the line and people perhaps can't see a clear path for themselves on exactly how they're going to return to the sort of access that they might have had to a health professional before, people are starting to raise concerns and queries about that. And we're starting to see, we're trying to discourage complaints about that because obviously there are clear reasons why people haven't been able to access some of their routine care over the last few months. We're trying to encourage people to ask questions about what they can access. But if you've been waiting for something for 3 or 4 months longer than you thought you were going to, any additional wait can make something seem like it's urgent at this moment. We've talked a lot with people about the importance of clear messaging. I think it's incredibly apparent that as the messages around COVID-19 have become more complex, that have come out of the centre, actually people are more and more confused and less certain on what to do. So there's something about a real need for a clear narrative from Kirklees as a place about what we are expecting of the general public, how we want them to interact with services and what is available to them. I've heard some feedback, both coming into us directly and through some of the meetings that I've been involved with, about increasing numbers of people accessing accident and emergency because of mental health needs. And I've asked for some further information about that, whether that's people who are unknown to services, who are presenting for the first time, who have become unwell across this COVID period, or whether that's people who haven't been able to access their regular care and that's led to a deterioration in their mental well-being. But I think that's something that's quite interesting in terms of how people are starting to re-access services. We've heard a mix of feedback about improvements in kind of digital access to healthcare services. So for a lot of people, actually, it's more convenient to be able to have a telephone or video call appointment. So we've had quite a lot of positive feedback, but most people, even if you really, really value that digital offer, still feel that at some point they need some face-to-face interaction with a clinician or a specialist, and there's something about getting that balance right as we move forward, retaining the safety of staff and patients, but making sure that people still feel like they're getting the level of access they need in order to manage their health conditions. And obviously there are some people in our communities who face much greater barriers in terms of accessing services digitally. And I think there's a big piece of work for us to do as a place to think about how we could make sure that people who don't have that access now are enabled to get that access going forward, if that's going to be part of the way that we expect people to engage with health and care services. Just whilst the other colleagues were speaking, one of the things that I'm really interested to think about, and this is as a result of the feedback that we're getting, is obviously we're concerned about a surge in demand for, sort of around the time when flu might be more prevalent, where we might have a second surge with regard to COVID-19. Actually, I'm concerned about a surge that also comes from people who might have had their needs addressed earlier in their presentation, in previous months and years, but that actually are sort of waiting in the wings for care at the moment, who might have an increasing level of urgent need at a time when we are already going to be incredibly stretched going forward. So I think there's something that would be interesting for me to understand about how we're preparing for that level of need across winter, as well as flu and COVID-19. I hope that's okay.
Thank you, Helen. Can I invite Emily Parry-Harris from Public Health to say a few words?
Hello, everybody. It's nice to see you all. Thank you for the invitation to come and talk to you. I hope everybody's keeping well. I'm Emily Parry-Harris. I'm a consultant in public health, and I'm head of public health for Kirklees Council. I'd recognise a lot of what my previous colleagues have just said. Very, very quickly, our current position, our current focus, in public health is ensuring that we are proactively reaching into those communities where we are currently seeing increases. There's a system set up now that we receive the data on a Tuesday. That we will review that data. That data will go into a member-led outbreak control board on a Tuesday, and Cabinet will be briefed on a Tuesday night. Members in those particular areas where we're seeing increases will be notified on a Wednesday alongside the MPs and the CCGs. And then we're mobilising community-based outreach on a Thursday. So that's a very kind of rapid turnaround. We're very much the emphasis is being on being fleet of foot, because we are talking about small numbers, and if it's ward A, B and C this week, it may well be wards E, F and G the following week. So we need to be very fleet of foot. So that's our main focus. I think Helen's point about the messaging is really well made. The messages about COVID have stayed the same since the beginning of this. You need to wash your hands, you need to wash them well and frequently, you need to not touch your face, you need to isolate if you're symptomatic, you need to access testing. We need to make sure that we are not overcomplicating the messages. We don't change the messages, we just change the ways in which we're giving those messages in order to make sure that we are penetrating our communities. A couple of really good news things from my point of view. Childhood vaccinations, I'm sure, would be of interest to the panel. We've seen that they have stayed broadly at the level that we've always achieved them in Kirklees, and we're good at childhood vaccinations in Kirklees. I know at the beginning of this COVID outbreak, I was concerned that we might see a drop in MMR vaccinations and then see a measles outbreak. I'm reasonably confident that we won't be seeing that. The other interesting thing to note is our breastfeeding rates are better than they ever have been. So there is something about being at home by yourself with your baby and having that time that a lot of women are feeling that they're missing out on some of the things that are associated with very early parenthood. But let's find the things to celebrate. Our breastfeeding rates have gone up slightly. So I think that's really interesting and clearly something for us to learn from. in terms of how we keep them up in the future. Helen made the point about digital access, getting some really good and positive feedback about how people are preferring sometimes, if it is their choice, to receive their information digitally. I've been working for 20 years with the NHS to try and improve people's access to digital consultations. We can do it now, so we need to keep some of this this stuff as we go forward. I'm conscious that you're trying to keep to time, so I won't say very much else other than I'm very aware of the potential health debt that is being created by COVID. So those people who haven't accessed screening services, who haven't accessed care at an early stage of disease, and I think that's something that we really need to keep a watch on and respond to. That was all I was going to say. I'm happy to take questions.
Thank you, Emily. We also have Richard Parry that's part of the meeting. Hi, Richard. I'm not sure whether you would like to say a few words before we move on to questions. Hello, Richard. Okay.
I'm not sure Richard's actually here, Councillor Zaman. I can't see him.
All right. Okay. Okay, that's fine. Okay. Well, without further ado, then we will move on to questions. And who would like to go first? Are we indicating? If you indicate in the chat.
Right, can I ask a question now, yeah?
One minute. Did you type in that you wanted to speak, Leslie?
I did, but then as I was doing it,
I'm not. Yeah, I'm not. I can't see it. That's why. But yeah, go ahead.
Wait, it's okay because there's other people ahead of me. I'll come.
No, I can't see the list. That's why I'm saying you go ahead, Leslie.
Right. Okay. So both. Thank you for your presentation, Emily, and the earlier ones. I mean, there are clearly there are still a lot of questions, are there not, about, I think the number one thing for me is challenge is a word used, and clearly that has been an enormous challenge for everybody involved, like we've never seen before. And the initial communication issues that you had to deal with and who was doing what, etc. But that said, the thing that is at the back of my head all the time is that we were already short-staffed before this began. You're working, all the staff and everyone I know who works in it, we've had quite a number of staff who have been having to isolate or be at home. And I'm just wondering, I often use this analogy, bloodstone with the staff. At what point, particularly if a second wave comes, are you going to be able to cope with running so low on, given that your staffing is well below what it should be, as it is nationally? That's the first question.
Okay. Who would like to answer that question?
It's Martin here. I'll happily have a go at that. As it happens, we had probably about 300 less inpatients than we usually have. Certainly 200 less, and that enabled us to close a number of wards and deploy the nurses from those wards onto the wards that remained open. Also, there was very little operating theatre activity. It was only emergencies really, and extremely urgent cancers. And so we were able to redeploy some operating theatre staff to work in intensive care and high dependency units and so on. So in actual, and outpatient activity slowed down dramatically. So we were able to have more doctors and nurses working on fewer wards because there was less other clinical activity going on. But of course, this happened in April, realistically, by which time many of the traditional winter pressures had eased and the better weather was coming. And I think we are all understandably anxious about what this late autumn and winter is going to bring. And that is why there is a lot of fear and anxiety, and particularly fear and anxiety amongst the staff who are working with the sickest patients in intensive care and the high dependency units, because they don't want to have to relive the great emotional and physical demands that were placed on them. You know, some staff had pressure sores on their faces because of the impact of the very close-fitting masks they have to wear, as well as the extreme heat because of the type of PPE they had to wear. So there is, understandably, for all sorts of reasons, a lot of anxiety about what is going to happen. And yes, so we got through, from a staffing point of view, a lot better than we could possibly have hoped for. And also the peak was only half the numbers that we were expecting the peak to be. So the peak was not as high as we had all planned for, as Dr. Birkin had indicated earlier.
Thank you. But can I just ask though, because at the moment, I was talking earlier, we all know that there are many people, and particularly the younger ones, who all think it's over. And in our communities, it worries me a lot, as someone who's been sheltering anyway, that I will go outside my house and there are endless groups of people and families. And, you know, like tomorrow, when in theory people are meant to be wearing masks, and it's, you know, that is, I know it's more a role for the councils and the trusts, but it's how we get that message over that this is so not over. And that is a really concerning issue. I mean, I know there's been an increase. Has there been a bigger increase in the use of independent sector? Because I know that you've had to use it for a number of issues, or is it a part of what you would do anyway?
So the local independent sector hospital that we are using at the moment is, we don't normally refer patients to it, but it is what is called an NE qualified provider. So in usual circumstances, it still does a lot of NHS elective surgery, but that is because GPs or patients choose to go there instead of Pinderfields or Dewsbury or Pontefract hospitals. But at the moment, that activity is paid for, I believe, by NHS England, and we are transferring work there. But of course, it's our doctors who are undertaking the medical work. The nursing staff and all other staff are employed by the hospital. But of course, it's our doctors and anaesthetists doing the operations and anaesthetic work and outpatient work.
Okay, thank you.
Emily, would you like to comment on that?
Yeah, certainly. It's not a comment about the hospital staffing. It was more a comment on the community response from the local authority point of view. Now that we have this specific data that tells us where the particular increases are, we are able to become much more targeted with the messages that we're giving to people. We are increasingly aware of where there are communities where people are less compliant with the guidelines. We've been doing some very interesting community-facing work to find out why people are less compliant with the guidelines in particular areas. the real challenge for us here is to get those messages out universally so that everybody knows that the virus is still with us, it's still circulating, and that there is a level of personal responsibility that we need people to take in order to stop it from circulating. The only thing that's made any difference to the level of the virus circulating in the population has been hand washing and social distancing. Very pleasingly, we've also seen a really significant decrease in reports of things like diarrhea and vomiting, because who knew that washing your hands frequently would make a difference to that. So we need to be much better at getting the message out there. The messages are really, really simple and straightforward. You wash your hands well and frequently, you maintain social distancing, you do not mix with lots and lots of other people. If you are symptomatic, you get tested. If you have a positive result, you isolate, and those that you live with also isolate, though your contacts also isolate. They are simple messages. They are difficult for some people to comply with. And that is something that's becoming increasingly apparent. So the community-based response is very focused on supporting those people who need additional support to be able to comply with those messages, to be able to do it. The use of face coverings is a really interesting one. It's a real point of pedantry on my part. I'm really sorry, councillors. Can we talk about, when we're talking about face coverings for the general public, can we call them coverings, not masks? I'm so sorry. Pedantry is such an unattractive quality. But face masks are a specific piece of surgical kit that Martin and his lot need. The general public need to be thinking about the use of face coverings. There will be some people, I've already bought some rather snazzy ones from Bowden. They match my dresses. I'm going to look a picture in my face coverings. Not everybody has that opportunity available to them. But we are doing work alongside the food banks, who have been brilliant in this. Our third sector, I cannot tell you how marvellous they've been. But we are working alongside the food banks to make sure that people who need support to access face coverings are able to have that support.
Okay, thank you for that, Emily. Can I bring David Rigby in next? David?
Yeah, thank you. Yeah. Question. I just wondered, are you getting access to all the named patient data you need in order to do track and tracing?
We're getting there. We're getting there. We will have. We will be receiving patient identifiable data towards the end of this week or the very beginning of next. The trace and isolate, and again, this is another point of pedantry. The programme of work is called Trace and Isolate. One of the interesting things from our community is they really, really dislike the use of the word track. So we're trying really hard not to use it. So it's trace and isolate. Yes, we're getting the data that we need in order to be able to do it. At the moment, we're still only getting postcode level data rather than household level. So it will be even better when we get the household level data, but it's so much better than it was.
And when are you likely to get the whole household level data coming through?
Hopefully beginning of next week.
Okay, thank you.
Emily, just a point of clarification, the data that you will get is people who have actually been for a test. So those that are not being tested, we don't have any numbers on that, do we, that may have had COVID?
Well, no, because the only way that we would know if somebody had had COVID is if they'd had a test. So yeah, absolutely. We're only getting the data through on people who have had a positive test. We're also starting to get some data through on calls made to 111, where people have described symptoms of COVID, which we can start to use as part of our early warning system. So the data is getting much better, so much better than it was.
Mm-hmm. Okay. Peter, would you like to ask your...
Thank you, Chair. Yes, Emily. While we've got you, please. I just wondered what the interface was between yourselves and Public Health England, who seemed at the start to be control freaks as far as this was concerned, and seemed to render everybody in your department relatively powerless. And I just wondered if that was a misconception amongst the laity, or if there was some truth.
Oh, I don't have a career as a poker player in my future, do I? I think on a personal level and on a day-to-day working relationship between Kirklees Council Public Health and Public Health England and the consultants in communicable disease control who we work with, we have good working relationships. The frustration at how the data flowed at the beginning of this was very real. And I think we are now in a space where people are recognising that actually the people on the ground, the people who know the communities, need that data in order for the system to be efficient. So, yeah, a level of frustration at the beginning. It's better than it was.
Thank you. I mean, Dominic Cummings is not watching this, so you can say what you like.
I'm not sure I can quite say what I like, Peter, but yes.
No. Where are we at with the app? Because I talked to a lot of people, colleagues internationally, and everywhere that's made a better fist of this than us seems to have got an app that works.
Yeah. The most honest answer, Peter, absolutely no idea.
Oh, right.
I don't know. It's not something that I haven't even thought about the app for a couple of weeks, actually. I'll go away and find out. I've not a clue.
No, well, it wasn't meant to be a trick question, and really, just a last one, please. Is how well is the system working? I'm thinking about this with regards to a second wave. Is there anything we can learn from things like the Cygnus exercise?
Yeah, there's a huge amount of. I mean, can everybody just touch wood for a second? While I say that things seem to be going all right, but please touch wood and keep your fingers crossed and hope
Mr. Johnson says it'll be over by Christmas, but we've heard that said before.
Which Christmas? Everything is going okay at the moment. We've got brilliant working relationships. Martin and his colleagues from CHFT would also be able to comment that actually a lot of what we've been able to do in the response to the COVID crisis has been in spite of organisational boundaries. We've learned a huge amount about how we work together, about how we don't worry so much about what it says on the lanyard around our neck. We worry about the outcome that we're trying to achieve for our population. So there have been some wonderful things happen over the course of the pandemic. In terms of how ready we are for the next wave, I think Martin's talked about how tired some of his staff are. I think there's a whole different way of how we respond to the second wave, given that we are 17 weeks tired. And I think we have to recognise that. One of the things that I can't remember if it was Martin or CHFT talked about, the real drop off in attendance at A&E and how people have clearly been able to take a level of self-care and not been presenting to A&E for some of the things that they would have done otherwise. We've really got to capitalise on that because we need the level of activity in A&E to be as low as it can be. The flip side of that same coin is there are some people who probably should have been presenting for care at A&E who weren't, and some of these messages are really tricky to find that balance. So I think my position sitting here now, end of July, in my little box bedroom, is that the system is okay. And we have the capacity to deal with a second wave, as long as we get on the front foot with getting these messages into our population that it ain't over, and that you need to continue to socially distance. That would be my caveat.
Thank you very much. Thank you, Chair.
Thank you, Emily. Andrew, are you wanting to comment on the current question that we have?
If I may, this is really to support what Emily just said. I think what has been tremendous across our health groups is the collaborative working. At Mid Yorks, we work with 2 CCGs. We work so collaboratively together. We met all together very early on in March, and we continue to meet. The patient pathways we're working on at the moment to try and make sure they are as efficient as possible, so that if we can, we deliver one-stop shops. So we're trying to reduce the footfall on the site so patients feel more comfortable that they're not having to frequently attend the sites. I think the comment about emergency departments, well, our accident emergency departments are back up to near full capacity in attendance at the moment, with, as mentioned earlier, significant amount of mental health attendances, and that is a really area of concern, which we are talking about with our collaborative partners to try and ease and identify where we can assist those people moving forwards. I think it's a real challenge. I think we have to continue to work as collaborative as we can through our pathways, make them more efficient and effective, and ensure that we are giving patients the care they require, but making sure equally that they are attending the right port of health at that time. I'm really concerned at the moment, and as I said earlier, I'm an emergency medicine consultant. We have a number of patients attend the emergency department because they feel they can't go and see their GPs. And we're working with our CCG colleagues to try and address the messaging around that to ensure that people are accessing the right port of care so that we can keep our emergency departments for looking after our emergencies for those people that need to come. So again, it's very challenging, as Emily says, to try and get across the correct message to ensure that people feel that health is there for them, that they should attend health if they require it, but the right port of call is extremely important.
Can I just add to what Andy and Emily have said, to say that Kirklees Social Services Department were brilliant in March, late February and March, and have continued to be so in terms of absolutely hugely cutting any delays in discharging patients who need social care support when they leave hospital. It's been one of the game-changing things that prior to COVID, we typically had about 110 to 130 patients who were medically optimised occupying one of our beds. And since COVID, that number has been about 30. Absolutely fantastic. So thank you.
Thank you for that. We have a question from Lynn.
Thank you, Chair. My question relates to one of the pages in the Calderdale and Huddersfield NHS Foundation Trust presentation, but it would be interesting to hear from both trusts if possible, please. And it's on the page Planning for the Future, where it refers to some services being suspended during the pandemic having now been restarted. And what I wanted to ask is, which are the ones that haven't been restarted, please? And is there any timeline projection relating to those? And just to say, I am well aware that any projected timeline will, of course, be subject to the COVID-19 dynamics in terms of perhaps a second wave of the infection. That's my question. Thank you.
I can answer that for Calderdale and Huddersfield, and David might want to add to what I say. I think in terms of during the pandemic, we stopped receiving new referrals into the hospital for non-urgent care. We have reopened to receive those referrals. What we can't say at the moment is that we have sufficient capacity to then offer treatment to all those patients for whom we have accepted the referral at this point in time. And that is the work that we're undertaking at the moment around prioritising based on people's need for care within those referrals that we've received, to make sure that those with the highest clinical priority are seen first within the capacity that we have. And I think, as has been expressed already, our ability to see people is severely restricted by the requirements around wearing personal protective equipment, around social distancing within the hospital, and all of the infection control process. So unfortunately, and we do know that this is a key area of anxiety for many people, we can't be definitive about saying when some of those services will be able to meet the needs of all those referrals that we have received. We don't foresee that will be in the short term. We are planning to, as we move forward, to be able to give clearer messaging by services to members of the public. I think it's a very difficult time, and of course will be impacted by what we see happen in the coming months during the winter period. But we are now fully receiving those referrals, and all of those referrals do have an initial screening around their urgency and prioritisation.
Thank you. Helen, would you like to come in? You wanting to comment on Andrew's point?
Yeah, sorry, it now feels sort of slightly out of sync because of what Anna's just said. I made a point similar to this this morning, and I understand that that this is not what Andrew is saying. I have a real concern about members of the public sort of it being indicated to them that they are getting it wrong in terms of where they try to access health and care. And that's not what Andrew was saying. It's just sometimes that when that information gets passed through layers and layers of people to the people on the front line, actually the message that gets through is, oh no, you've come to the wrong place, you should have gone somewhere else. And I think we need to be really considerate about how we communicate that, because there are places that have better specialism for certain things, but actually I have real concern about people feeling discouraged from accessing the health and care that they need, because perhaps they didn't approach the part of a service that they that was exactly the right place for them to go to, and how I just worry that that can be really discouraging. And there's something really important about the way in which we indicate to people that there are other options that might be better for them if they're seeking a certain answer, because we often hear from people that they felt like they rang the wrong number, they were sent somewhere else, they were told they shouldn't have gone there, and I think that that is a really important thing for us to recognise when we're thinking about how we sort of move things forward and make sure people get the care they need whilst we're trying to do it in a new and different way.
Thank you for that. Thank you, Helen. Can I bring Dave Rigby back in? Dave, are you wanting to ask a question?
Yes. I was actually wanting to ask a question, 3 questions of Richard Parry, but I understand he's not here. So I just wonder what's the best way, could I get the opportunity at some of the time to ask them?
Yeah, if you put them on an email and send them to either myself or Richard, we'll get them to him.
Okay, thank you.
Okay. Alison Munro, would you like to?
Yeah, thank you very much. I just wanted to come back on it's the point that Helen's just spoken on, actually, and it's in connection with the right port of call. And while I appreciate, I just want to say, while I appreciate it's important that people do go through the right port of call, but what happens, for example, if they've had difficulty in the first place accessing their GP as their condition that they've discussed, it may not be seen as a priority, so they may have been put on a waiting list, and then they may feel that perhaps their symptoms got worse, but they were on a waiting list. So, well, rather than stay on the waiting list, perhaps we'll go to A&E. Perhaps I'll be able to see somebody then. So I think we need to have a clear communications with people here. I think would really help a lot more. Because people may become frustrated or worried or even concerned if they're just on a waiting list because their condition isn't seen as a priority. Yet actually it may become a priority, or they may become more worried about it, which could explain why they're not going through the right or correct access point. So I just wondered what could be done about that. Thank you.
I think if patients experience a deterioration in their symptoms, they should contact their GP, because the GPs have the ability to escalate a routine referral or even up it to an urgent referral. And that would be the best way. Obviously, if it is an emergency situation that can't wait until they next speak to their GP, then contacting 111 and so on, is clearly the best route.
Okay, thank you, Martin.
Thank
Andrew,
you. Yeah.
Are you wanting to come in there?
Yes, I'd just like to reassure everybody on the meeting that while I work clinically in the emergency department as well as my other roles, and I last Wednesday did a very long shift, and I saw a lot of people that were literally attending because they were concerned and they wanted to see somebody. And I can reassure everybody they were seen, and they were seen. What we put in place is a consultant at the front door to ensure that they are assessed by a consultant, and we help them understand what needs to be done for them now, and let them understand what's the best way to access the correct port of care for them. No one's been turned away. We have seen everybody. We are assessing them, and we're making sure that it's a senior clinician that is involved in that assessment to often offer reassurance. And I think at the probably well over 50–60% of the patients I saw last week in my clinical session, I was able to provide reassurance, and they were most grateful for that. And I think it's no one saying you can't access. If you do access, we'll assess, and we've made sure, and I'm sure some of my colleagues at Calderdale, that the senior person is assessing them so they can be reassured that their condition is where it can be managed appropriately.
Thank you. Peter, you wanted to ask a question?
Thank you, Chair. Yes. It's really one for the clinicians, please, if I may. We all follow the reports with interest about the impending vaccine, and yet we also read about the mutations that seem to be happening with this organism. I just wondered, from a therapeutic point of view, whether there had been anything which offers any hope. I know that there are a lot of drugs trials going on, and we've all read the reports about things like dexamethasone. And I just wondered if there was any light at the end of the therapeutic tunnel, please.
I think we're surveilling this all the time, the information coming through. One of my roles during the whole COVID process was to access all the information that was coming into the trust and ensure my colleagues were kept informed, and we continue to do that. The information coming through, there is real hope in the vaccinations, but we have to be aware that the antibody profile is a key piece of work that we need to see the results on in due course. It is suggesting a large study done in London that the antibodies do not remain for a long time, and that they could be anything between 3 to 5 months. Therefore, the vaccination process that we're required may not just be one injection, it may be several, to provide a boosting system. Clearly, I'm not a scientist, I'm not a virologist, so we are waiting for that information to come through to us. But we are hopeful that come next year there will be a vaccine available, because that's the important step to ensure that we do generate herd immunity and to move us away from the cycling that's taking place potentially at the moment.
Thank you.
Do you want me to come in on that question?
Just very quickly, if David Birkenhead has any comments to make on that.
So I very much support what Dr. Smith has described. I think, there are some therapeutic agents out there now which are moving out of the trial arena. There's an antiviral called remdesivir, which seems to show a positive improvement in terms of duration of symptoms. And I think dexamethasone is important. That does seem to have a benefit in terms of improved outcomes. And there was some stuff that I noticed in the press over the last few days on an inhaled drug called beta interferon. And again, I think we're waiting for more data around that for that to be published. But again, there are some agents which are showing promise. I think the vaccine is going to be important for us. How long-lived that will be, I think, is an unknown question at the moment, and whether it provides protection. But until we've got through those trials, we just don't know.
Thank you very much. Thank you.
Thank you for that. Can I just ask both the trusts if they're likely to be any changes to any of the services, and how are they likely to be delivered in the near future?
Shall I go first? I mean, there are changes. So I think the changes are likely to be during the next 9 months, until there is an effective vaccine and lots of people have been vaccinated, and we return to something that we all recognise of the lifestyles we had before March. In the main, I think it really is about the much more use of the telephone and video consultation for outpatients, infection prevention control measures absolutely dominating the organisation of inpatient services within hospitals. I don't think the amount of X-ray diagnostics is ever going to get back to where it used to be, this side of effective vaccine. So I think the infection prevention control is going to make a lasting impact. I think if we go back to the NHS plan, where the ambition was 30% of outpatient appointments, would be telephone, video, or patient-initiated follow-up. I think we're there already, actually, if not more so. So I think that, that 30% is probably likely to stay forever, and it is of benefit to a lot of patients because it saves coming into hospital car park charges and everything else. So I think that is one of the changes that is probably going to be sustained, I would guess. But I don't think there'll be many other seriously permanent changes to the way things have been done in the past other than that. I think for staff, I think it's likely there will be more home working. I think that's worked pretty well for some colleagues. So I think they're the two main things that I would say.
If it's okay, councillors, if I can comment as well, I think I agree with the points that Martin was making. We have made massively rapid progress towards the 30% digital consultations. We really do need to keep that. I think I mentioned in my introduction, we need to keep these things that have worked well for us. The benefit to the environment at the beginning of lockdown, when we saw a massive reduction in the number of journeys that were being undertaken, had an enormous impact positively on the environment. Given and we don't understand COVID yet, we are learning about COVID all the time, but it's a respiratory illness. It's not unreasonable to suggest that a respiratory illness would be impacted on by better air quality. So anything that we can do to keep our levels of emissions down is really, really positive. And I'm not sure I agree with you on Microsoft Teams, Martin, but I'm getting much better at it than I was to start with.
Okay. Can I ask the Huddersfield Trust to
I think we would echo the comments that Martin has made about the longer term future. The use of digital technology to provide different forms of access is something we'd want to sustain and amplify. We were pre the pandemic, had gone quite a long way down that route, and this has really accelerated it and is something we would want to continue doing because of the benefits it does have around convenience and access. We're really keen around that to make sure that we do fully understand those members of the public who can't access that technology or have difficulty or need support to use that technology, that we don't inadvertently widen any inequalities. But absolutely echo that as a direction of travel. I think the other area that we don't want to go back on is what's been referenced around the collaboration across organisations has been really amplified during this period about doing the right thing. We always sought to do the right thing, but sometimes that was constrained by some of the way we work in different organisations, and we want to really keep that momentum of working together. We've had some tremendous examples. I'd echo the comments around working with social care colleagues, working with hospices, working with GP practices and with local pharmacies. and we want to continue to do that. I think, unfortunately, I think you referenced in the short term as well what might happen. Of course, the changes in services that could happen in the short term would unfortunately mean that we would have to reenact some of the things that we've been able to stop doing since the peak of the crisis, such as suspending some of our services, subject to how the demand occurs during the winter. Unfortunately, we could be back into that place, and that's what we all want to avoid. And that impact of social distancing and actions to stop the escalation in the number of cases is critical to that.
Thank you, Anna. Leslie, are you wanting to speak? Your mic is off. Hello.
Yeah. I'm not quite sure how to frame this question, but it's based on the fact that I have quite a number of friends who are on their own in my age, as in from late 50s, 60s, you know, heading upwards. And clearly there's immense amount of anxiety. And on the whole, those are the people who are doing the social distancing. I have a question about psychology and considering you've got the symptoms, because if you look at Facebook, which unfortunately in my role I have to do a fair bit, you would believe that vast numbers of people have self-diagnosed themselves because they've seen these symptoms. I've got this happening with 2 or 3 friends, and yet it's not consistent. And I just wondered if it is possible that people can psychosomatically believe that these symptoms are there. It's how to reassure them. Obviously, in doubt, stay at home, rest, all the usual that you've talked about, Emily, and that we all know. But I just wondered if you're seeing a larger number of people than normal worried that they could have when they don't. And I know, but maybe there isn't an answer to it.
Yeah, and I'm very conscious that I'm not a psychologist, so I don't want to kind of stray into areas beyond my professional expertise. The one point that I would make is that if people do genuinely believe themselves to have symptoms, then they should get tested, because we need to know where this virus is in the population. So if they think they think they have symptoms, then they need to either access the NHS website or ring 119 and follow the instructions and get a test. In terms of the psychological, the symptoms are loss of sense of taste and loss of sense of smell. I could imagine how that could be psychological. A cough is a cough is a cough. You've either got it or you haven't. And a high temperature is a high temperature. You've either got it or you haven't. They're biological things. They're markers. They physically exist. I don't know. I'm not a psychologist. If they think they've got symptoms, encourage them to get tested.
Yeah. Thank you.
Okay, Helen, are you wanting to come in?
Thank you. It's an observation really, and a comment more than a question, and just something perhaps for us to consider, because obviously I'm involved in a number of different conversations like Health and Wellbeing Board, etc. I'm really aware that a lot of what we are talking about is practical preparation for the future, for potentially what winter might look like, all that kind of thing. And that the best way to protect us against having problems across that period of time is to make sure that the public are skilled in a way that means that they aren't at risk. And I'm really mindful that we talk a lot about communicating and how important it is, but perhaps we haven't prioritised the communication strategy as a place in the way that we should in order to try and keep people safe in the first instance. Then it's easier to prepare for going forward, because actually we know that we can rely upon the people living in Kirklees to be doing the things that are right for them. So I was really interested in what Emily said about getting out into the communities directly and having those conversations, because I think that's what's really pertinent and really important. But there's still something for me about, we talk a lot about how important communicating is, but I'm not sure that I've seen anywhere that plan that helps us all to work together in the health and care system to share the same messages about how people keep themselves safe in the current situation.
Thank you. Is there any further questions? Okay. We'll move on to thanking everybody for attending. I believe that you're doing a superb job under very, very difficult circumstances. We note the information that we've received and agree that we continue to monitor the situation, and we will look at the position again when we discuss winter pressures at the panel meeting, at the next sort of panel meeting. Thank you for attending.
Thank you very much.
Thank you for having us. Stay safe, everybody.
You're
Take
welcome,
care.
everybody.
Bye.
Goodbye.
The setting of the work programme. Now we can just sort of quickly look at some of the comments from the officers or the partners, and look to see where we go. Because at the moment we have to acknowledge that we're having less meetings because of the situation we're in, and we just don't have the capacity to undertake as many as we were previously. So if we can think about what we want on the agenda for the next meeting, because we have to be very tight in terms of our priorities to ensure that we are meeting. Sorry, there's some background interfering noise. Did you get that?
Yes, thank you.
Yes, thank you.
Okay, yeah. So just in terms of the work programme, if we can quickly go through that. So number one is the financial position of the Kirklees Health and Adult Social Care Economy. Is there any comments on that?
Yes, can I speak on that?
Yeah.
Yeah, I think that's of high importance. And I also think if included within that, we could be looking at issues affecting the viability of care homes.
Within this item, yeah?
Yeah, within that item, yeah.
Okay. Okay. Any further comments on that? We'll move on to community care services. And again, if you look at some of the comments from the CCGs and Health Watch.
Yeah, I mean, I don't think it's an immediate priority, but I do think it's something that we need to be thinking about because it's obviously been impacted by COVID. So looking at some of the comments, and they're suggesting that we set the discussion in that context, in the context of COVID-19, to see how it has impacted on them, on the PCNs. That's just my views on it. But I don't think that's an immediate.
But we can include that within that. I mean, it's not a major issue. That okay. Number 3, Kirklees Integrated Wellness Service.
I'm sorry, I'm going a bit quick for me. I'm not keeping up with you. Can I just ask, under community services, there's 2 things for me. Although we've only got 4 meetings and we've discussed that for the moment, that's all we're allowed to meet. I'd like to re-emphasise the point that we brought up last time we met, which was that at a time where I believe firmly that the NHS is under not only severe pressure, but more and more things are being privatised that we're not hearing about. And I want to be able to meet more often, even if it's more workshop based, where we, between us, can discuss the issues and possibly be more efficient when we meet. And one of the issues that is still not being answered is the questions that happened about Lacala and the social care provision and where that public money went when they sort of closed down that company. Now I know that's for a future meeting, but I don't want to let things like that go by the board, because I think there's so many bits you hear going out to privatisation, coverings, masks going out to people's friends, and there's a lack of tendering and open transparency at the moment that is concerning me. So you know, I think we've got a really important role at the moment. It's never been more important to keep scrutiny for health and social care. So, you know, there's a lot of topics here, and it's all very well saying we have to be efficient and do that, but I also don't want to miss things.
But we can have informal meetings if needed. It's just because of the technology that is involved that, you know, we're restricting meetings in public.
Okay, but if we had some more informal meetings that we could maybe thrash out our views or questions about things, we might then be able to be more efficient when we actually have the public meeting. Are you with me? So if we're only allowed four public meetings, and prior to that we'd had 2 workshops, the public meeting could be more debated and thought through, and our questions have been put to whoever, so that when we have the public meeting, it can be more, get a bit more in.
Okay, can I bring Richard in to comment on that? Richard?
Yeah, thank you, Councillor Zaman. It was just really just to pick up on the points that Councillor Warner mentioned, excuse me, regarding workshops or informal meetings. And I think we do recognise that the ones that we've done in the past have worked well. I think we've had a reasonable reception from panel members in terms of the approach we took to those. So I don't think there is any reason why we can't, if that's what members want, look to arrange some informal workshop type sessions so that you can get a greater understanding in terms of some of the context and some of the issues that you have flagged. So if members are happy to do that, then that's absolutely fine. I think the key thing for me in terms of the work programme is that we've obviously got a cycle of formal meetings, which obviously are laid out in the agenda. And I think it'll be helpful is as part of the work programme discussion, we're really clear about where your priorities are, so that when we start planning the work schedule, I can focus on getting the arrangements in place so we can have those formal public discussions around the schedule of meetings that we've got, and then some of the other stuff that's particularly in some of the stuff around Locala, for example, and others, we could perhaps pick up as part of our informal sessions. So I hope that helps, Chair.
Yeah, absolutely. Okay, is that okay, Leslie?
Sorry, I mean, yeah, it's okay as long as I mean, is the proposal that everything down on this agenda for the work programme is what we're trying to prioritise? Because there are clearly some things that could go together. So you were about to move on to number 3 on the integrated wellness service. But I think highlighting at the same time the increase in mental health and issues is something that, and how, you know, how we are coping with that. I mean, I think I talked before that within our area in the ward, we have prioritised some money to provide counselling for young people over the summer. But I mean, it's the tip of the iceberg. And I, you know, as the furlough ends and more people are out, and there's a lot of lost kids around. When I say kids, I mean young people. So the mental health bit, I would like to be, you know, nearer the top of the agenda.
Yeah, I agree with that, Leslie.
If I can just, Chair, just to bring members' attention, under the work programme, we've got proposed new issues, and included in the proposed new issues is obviously a mental health services workshop. And I think this was suggested at the back end of the last municipal year, and I know the trust, mental health trust, are very keen to help support a workshop. So my suggestion would be, if members are okay with it, is that we could maybe have that in as our first
workshop.
Yeah.
Sorry, did you hear? I got cut off there, so I apologise. So maybe we have that as our first sort of informal workshop, so we can that'll actually start to help, I think, inform the programme and where we can maybe slot something in on a more public basis. So if you're happy to do, if you want me to, I'm quite happy to start to pull something together on that basis.
Yes,
Richard.
Good idea.
Yeah, definitely.
It's a good idea. Yeah.
Okay, I'll arrange that then.
Okay, so then quality of care in Kirklees.
May I just mention something about number 3, please, Chair?
Yeah.
Yeah.
The Kirklees Integrated Wellness Service. Just to say that I think that it links in well with the Kirklees Health and Wellbeing Plan, which spans the period from 2018 to 2023, and also, once again, underpinning mental health and emotional well-being will be the Kirklees Loneliness Strategy, which is currently under development. So it's just worth being aware that those link together quite nicely.
Yeah, we could look at both in November.
Yeah.
Yeah. Okay, so number 4, quality of care in Kirklees.
I think this is quite important. I think it should be quite high priority, and it does mention there about having a focus on adult social care, because we missed that last time round, I think. So it'd be good to have that if we consider this in the near future.
Yeah.
Yeah, and again,
It's an annual one, isn't it? So.
yes. Yeah, and again, with some reference, please, to care homes and quality of care in care homes, please.
Okay, we can add that. Okay. Number 5, we have suicide prevention.
Yeah.
Are members okay with that?
Yep.
Definitely, yeah.
Number 6 is the annual report from the Kirklees Safeguarding Adults Board. That's usually a presentation to the board.
Yeah, that's important, because it also, you know, if we have to go into lockdown again, you've got children, you know, the implications are, you know, children who may be at risk as well. I think that's an important one, as well as senior people as well. You know, people who vulnerable people.
Yeah, vulnerable people. Yeah,
Yeah,
definitely.
so just to be clear, just for clarity, this is for the Safeguarding Adults Board, so this wouldn't necessarily cover children. Obviously, there is a Safeguarding Children's Board, but I understand what you're saying. Is obviously we need to be mindful, don't we, across the board, I guess, in terms of that. But the focus for here is definitely on the adults side.
Well, yeah, okay.
Maybe something that the children's panel might well be looking at.
Yeah, I think we need to look at it, because I mean there are so many people who've had to self-isolate, and people who've been shielding, elderly people, you know, who are easily taken advantage of, and I think that's something. If we're going to a second lockdown, you know, that's potentially something that we need to look at.
Yeah, we do have a point on that. That's impact of COVID-19 on safeguarding adults and children during the periods of lockdown.
Yeah.
So there will be some sort of element included in that.
Yeah.
Okay. Number 7, the Mid Yorkshire Hospitals NHS Trust.
If I could just say, in relation to number 7, 8, and 9, I think they're important, but I wonder whether we could cover those by keeping a watchful eye on them. And if there's a specific issue that crops up, then bring it to the panel then.
Yeah.
That's a good suggestion, because that is something that we did discuss earlier, that maybe with some of these items, if we have written reports, that, you know, we do keep an overview rather than actually having presentations or input at the actual meeting.
And can I just add, in terms of 8, you know, this transforming outpatient care and the moving it is still very much uncertain. And I suspect that one of the things out of this outbreak will have done is make a lot of people be concerned about this outpatient care, you know, moving. I think that certainly needs to be kept an eye on, and listening to what's happening in terms of the people who are still fighting hard to stop the closure of that.
One of the things that's included in the district hospital is the visit to the hospital to have a look at the hot clinic and the frailty unit. And I suppose, you know, because of the COVID issues, we won't be able to do that for a while anyway. So maybe an overview of that.
Mm.
Okay, so moving on to number 9. Yorkshire Ambulance Services and the response times.
I think that's another one to keep an eye on.
Yeah, I do. Mm.
Okay. We have Councillor Smage that's part of the meeting. Liz, can I bring you in? Would you like to say something?
I was just going to say that.
Sorry, my meeting chat's not working, so.
Oh,
apologies.
sorry. Okay, all right. I just put something in the meeting chat to say that we're hoping to have a West Yorkshire Scrutiny Committee very soon. There is one coming up in August, and so if there's anything from there that overlaps with your work programme, we could update the panel from that. So, for instance, if there's anything happening on a West Yorkshire level on anything that impacts here, such as mental health or anything, we can
absolutely.
update the panel so you've got a little bit of help there. And we're also looking to see if we can put at some point in time a Calderdale and Kirklees scrutiny meeting in to update on what's happening with the CHFT. Okay.
Okay, thank you.
I think that would be useful because I think a lot of fears need still to be allayed about some of these changes, which I've already indicated, Elizabeth. So.
Okay, thank you for that. So moving on to Kirklees, number 10, Kirklees immunisation programme. So again, you know, we've said we'd be interested in understanding how the risks of the COVID may influence the immunisation programme, particularly if there's a second spike in the winter months. And then, yeah, is that okay? Number 11, update on winter planning. Again, some of those discussions have taken place through this meeting today, and if we can keep an eye on that at the next meeting, that we're planning on having more detailed discussions around that.
Yeah.
So in terms of some of the proposed new work or new issues, development of a local community care package, that's something that has been put forward by the Health and Adult Social Care Scrutiny Panel, and it will be a pilot. And then the other item is the mental health services workshop, which we've already just touched on. And the third item is COVID-19. And again, it's this Health and Adult Social Care Scrutiny Panels suggested that. And we look at some of the lessons learned. Sorry.
I'm just going to say, I think we said previously that it'd probably be good to have this as a standing item.
Yeah.
For our meetings.
October, yeah.
Yeah, but maybe rather than having detailed discussions on that, if we have it as a standard item, maybe we get an update from the partners, so that you know we're not spending too much time just discussing that, and you know we're able to focus on some of the more pertinent issues at that time.
Okay.
And then we have item 4, which is effectiveness of smoking cessation arrangements in Kirklees.
Might I just mention something about that item, Chair, please?
Yeah.
I do quite a bit of volunteering with people who've got complex mental health diagnoses, and obviously one of their coping strategies is often smoking, even though they appreciate that it may well be detrimental to their health. But sometimes going for just a weekly session at a chemist's shop in their little consulting room where the person they see isn't actually the chemist, it's one of the staff who's been trained to deliver the smoking cessation program. They don't really have the level of insight, you know, to understand the challenges that people with complex mental ill health face and how difficult it is to actually stop altogether. And I think there's a lot more support needed in that particular area if we're going to have success in supporting people to stop smoking. So I think sometimes the programme that's in place now, where GPs don't do it anymore, doesn't really make allowances for people who face a challenge on a daily basis because of mental ill health. So I think that's just something that, and I've experienced, you know, I've witnessed this myself with people I support. So I've seen how it fails. And the thing then is that people feel they've let down the people that's trying to support them to stop, but that they failed as well. And I've seen people then end up smoking even more. So it's quite a crucial issue that I think needs to be looked at in a little bit more detail, please. Thank you.
But is that because we've moved to more like community pharmacies and the role of GP surgeries has changed?
Yes, I think nowadays if someone's looking at stopping smoking, they're advised to go to one of the, I'm not sure if it is just pharmacies that provide it, but certainly the people that I've been working with as a volunteer have been referred to the pharmacies to get the smoking cessation support. And as I say, there's a little bit more to it needed and a bit more insight than just setting targets and goals and assuming that people are going to be able to take responsibility for sticking to them, because it doesn't always work.
And you could add that it's actually quite important at the moment, because generally speaking, COVID, whatever else it is or it isn't, is related to respiratory infections. So, you know, there might possibly be more people who would consider giving up smoking if they had support. So, I mean, that is something to bear in mind, I think.
Yes, absolutely.
Okay, well, thank you for that. Is there any further comments on that item? Okay, do we have any other business? No. Okay. Well, thank you very much, everybody, for attending. Our next meeting is scheduled for the 24th of September, and we will try and look at a workshop style in between now and September, if Richard has time, and some of the partners.
I'll do my best, Councillor Zaman.
Well, it's not just down to you; it's some of the partners that we're trying to involve as well.
Can I, just before we finish, can I just clarify one point? Obviously we've highlighted winter planning, haven't we, as being sort of like a key area of focus for the next meeting. Just looking back in past years, September sometimes can be a little bit too early for the trust in terms of having their full plans prepared and ready. So traditionally we've usually taken that in October. So what I will do is I'll obviously speak to the trusts, speak to all organisations to see whether they think they'll be in a position to be able to have a full discussion with us in relation to their plans. If they are not ready for the September meeting, obviously we'll need to think about what other areas that you feel are of a priority to cover potentially in its place. But if they do say their preference is to have it in, say, for example, in October, we've got a choice. We could either see if it's possible, slot an extra meeting in to October so we can cover that point. Although we do have an early November one as well, don't we, on the 5th of November. So it's possible that we might could take it then. But obviously what I didn't want to do is leave it too late, so that if there are any recommendations or comments that the panel want to make, I want to make sure obviously that there's plenty enough time for them to maybe act upon that. So are you okay if I sort of investigate what the kind of timings with the trusts and partners are likely to be, and then obviously I can liaise with everyone in relation to that. If just to help me, if we can't do winter planning in September, out of all the issues that we've been through today, are there any that particularly you would think you would want to bring forward as being a key area of focus for the panel?
I think the mental health workshop could.
Yeah, I think that's good.
Well, we'll do that anyway. So I think that we
Right,
can do that as an
okay.
informed workshop. But this is obviously a formal meeting that we've got scheduled. So I just want to sort of get some direction really in terms of out of the other areas of the work programme that we've identified. Is there any?
I think the first one, the financial position.
Yeah, that's an important
would be
one.
quite important.
Okay, that's fine. Yeah.
And also just whatever we can find out about what's going on in terms of the privatisation of small companies and more things going out, like the PPE, which was being done by a local company, has now gone back out to a company nationally that hasn't gone out to tender, and it just seems ongoing, and I don't know how we get to the bottom of it, but I certainly would like to know as much as possible, and I guess that's linked to finances, is, you know, are we increasingly paying more for services that, you know, were once in-house, like, you know, the social care, etc.
Yeah.
Locala. I mean, I know I keep mentioning it, but I'm concerned about it.
I think the biggest item at the minute on the privatisation agenda is the track, trace and isolate, which is being put out to Serco, whereas Public Health used to do it themselves.
Yeah. Okay, thank you for your comments and your contribution. I think we come to an end of our agenda. I'd like to thank you all for your participation in today's meeting. We're coming to a close of the meeting. Thank you everybody for attending, and stay safe and well. Hope to see you at the next meeting.
Thank you.
Take care everybody.
Thank you.
Thank you very much.
Bye-bye.